streaming live from lovely Colorado Springs tonight. Thank you to everyone who's attending in person. Thank you to everyone who's attending online. We're here to talk about MS with Dr. Enrique Alvarez. I'm Kelsey Morrow, Education Manager for the Rocky Mountain MS Center. I'd also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Bristol Myers Squibb and Genentech. This speaker series is just one piece of our education programming. We have a variety of formats available, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. Our next big event is our Fall Education Summit, which will take place on Zoom and also at Anschutz in Aurora, Colorado on November 16th. Topics covered will include research updates, the possibilities of CAR T therapy, aging with MS, and managing invisible symptoms. We announce all of our educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. And now I'd like to introduce you to Dr. Enrique Alvarez. Dr. Alvarez is our medical director at the Rocky Mountain MS Center. He is a graduate of the Medical Scientist Training Program at the University of Colorado, Denver, and completed his neurology residency and neuroimmunology fellowship at Washington University in St. Louis. He joined the Rocky Mountain MS Center at University of Colorado in 2013 and is now the director as well as the vice chair for clinical research. We did have a lot of great questions submitted tonight, so just wanted to let you know we'll get to as many of them as possible. We will group some of the similar questions together. And today's presentation is for informational purposes only. All decisions regarding MS treatment and medications should be discussed with your neurologist. Hand it over to you.
Awesome. I mean, this is for people that haven't been to these are open forums. So it's basically you ask the questions and I try to make up some answers that make some sense. So it's pretty easy that way. All right. We got all kinds of cameras and going on today, so trying to get used to that. We'll just open it up and start from there. People have any questions, burning questions that they want to get started on? Otherwise, we can start kind of going off the list that we got.
And if anyone has a question in the audience, if you could wait for me to get to you with the microphone, that would be helpful.
I've been reading a couple of articles online about walking backwards and how it might help with cognitive function as well as assist with balance problems in multiple sclerosis patients and as well as Parkinson's patients. Do you know anything about that?
I don't know much about that. I mean, what I would say is anytime you try to get exercise in, and especially if you try to do more challenging things with it, such as trying to walk backwards, you're going to just employ more of the brain and just kind of activate more stuff up there. And so I think as long as you can do it safely, and emphasize this with pretty much any kind of exercise, right? Because I think it's really easy sometimes to kind of say, well, just start working out, right? And then the next question we ask is like, how many falls are you having? Those kinds of things. So if you're having issues with balance, working on trying to do things that help work balance appropriately for where you are at, I think is helpful. But it's also then ways of how do you get exercise in without balance, or like stationary bikes or things like this might be good ways to do something like that. So when you're thinking about, I think, exercise, trying to be mindful of that becomes really important. I mean, so we can start with some of the questions that kind of came in. There were some that I'm just going to kind of group up together. And these are in no particular order. There are a lot of questions around sort of picking drugs and stopping drugs. So I think that that's always kind of a hot topic as we think about all the different options that we have now. And I think it's, I guess the polls are opening up or somewhere. The spam calls keep coming fast and furious. So I think when I think about picking drugs, right, there's certain drugs that may not be good options because they might interfere with some other drug you're on or some contraindication. But in big picture aspect of things, I think the important thing to think about is, if there's a drug that you're not going to do, right, that's not a great drug. So what are you willing to do, and where can we meet you halfway to kind of do that drug? I always point out that my bedtime routine is maybe not the best routine out there. And so doing a pill twice a day for me might be a little bit more challenging. If you're a little bit more structured than I am, that might be a lot easier than trying to arrange an infusion and having to deal with an infusion center and those kinds of things. If you're looking at trying to not do that, an injection, if you're afraid of needles, an injection may not be the best option. So how do you kind of find, so I think there's a few things that's, I think, where the first starting point kind of is a good one to kind of start off at. I think then if all things are kind of equal, there's been a lot of discussion around sort of treatment strategies around things like, do you start with high efficacy early? Do you do an escalation approach? And those kinds of things. And this was a pretty hot debate, I would say, 5-10 years ago. It's increasingly becoming less of a debate. More people are going towards doing high efficacy therapies early. I think a lot of times at the beginning, you're not quite sure where the MS is going to go, right? Early on, if you have 2 lesions, is that 2 lesions going to 100, or is that 2 lesions going on to 3? And we just don't have great crystal balls that tell us like where things are going to go. And so if you're really catching it early, I think it becomes really hard to kind of pick and choose at that time. If you're a little bit farther in and you've had sort of, one of these episodes that we sometimes call an optic neuritis or an isolated spinal cord lesion or a transverse myelitis, and you're stable for 5 or 6 years, and we've chosen just to kind of wait, watch a little bit because we're not sure if it was a one-time event or something else. And then all of a sudden, like 8 years later, you have a second something or another, and you made it 8 years without much of anything. Pushing to go for a high efficacy therapy may be something you don't need as much, but at least there you have some time to have made a decision, right? The other thing too is, you were on one of the mid-tier drugs and you come to me and you've been stable for 5 years. I don't know that there's a great reason for me to try and push you to go to a high efficacy therapy at that point. You've been stable, you're doing great on the drug you are, so let's just stay on that. Sounds good. And so as you're, so I think with that kind of starting off, thinking about higher efficacy therapies then early is kind of where things are going. I just heard a number that about 2/3 of patients nowadays are on B-cell depleting therapies. If you add in Tisabri and some of the other drugs, I'm sure it's getting close to, maybe being 3/4 of patients getting close to being on those higher efficacy therapies. So I think because of that uncertainty as to how you're going to go at first, that kind of maybe pushes us to saying like, let's not think about it and let's get you on high efficacy therapy because then we know we're covering you well. I think for the stopping question, then it's the issue of like, okay, so you were diagnosed at age 10 or 20, you're like 40 now, you've been treated stable-ish for 30 years. Do we keep you on treatment another 50 years? Or do we start thinking about, stopping treatment? How do we think about some of those things? So unfortunately, as we get older, things don't work quite as well. And part of that is your immune system, right? We tend to see more infections of the lung, pneumonias, and things like this as you age. That means the immune system can't attack your brain and your spinal cord as much as you get older either. And so it tends to kind of die out from a relapse perspective. And so usually when we're looking at sort of like, what are the chances? And again, this is at the population level because we don't know how each person's going to do. But at the population level, the number of attacks usually kind of goes like this. And it tends to plateau around the age of 60. Now, I have patients who are getting diagnosed at age 65. And there's patients who have started like way before that, right? So trying to kind of say age 60 is like the magic number doesn't quite hold up very well. So usually then you want something like you want to be stable for some period of time, 5 years, 10 years, 20 years, and you kind of mix that in with age. And it's usually a combination of those two things that kind of go into making a decision about, hey, let's stop treatment. I think the other thing is this is kind of a fairly new idea. And so it doesn't necessarily mean that we're done with you. We still want to keep seeing you in clinic. It means we're still going to get MRIs. We're still going to try and treat symptoms. We're still going to do things, together to try and kind of improve that quality of life. But it starts getting us thinking about like, hey, maybe we don't need to be on those high efficacy therapies, which sometimes we tend to associate with having more risk of infections and other things like this. And we already said, hey, as you're older, you're higher risk of infections. And so we have to try and balance that a little bit. So I think about it like a seesaw, right? Early on, there's a lot of benefit to these drugs. And as you're older, there's less benefit to the drugs. On the risks, it kind of goes the opposite. More risk as you get older, very little risk when you're younger. The other piece that we think about this are things like, what's your disability level? So we know that as disability accumulates, things don't work as well. So if you have bladder issues, you may not empty your bladder as well. So you're more risk of urinary tract infections. If you're having issues swallowing, you might be at higher risk of aspiration pneumonias. And so unfortunately, that higher risk kind of keeps going up a little bit with that disability level. So that kind of brings up, that conversation of, hey, we do get to a point where we need to think about the risks of the medicines as well. And it's not sort of a constant, it's a moving target that we're trying to adjust a little bit as the disease goes by. The other thing is because so many patients now with maybe 65% of patients being on B-cell depleting therapies, antibody levels can start to kind of come down. Antibodies help us fight infections. They're a marker of being able to kind of mount an infection, right? Part of the vaccine responses and things like this was that ability to mount an infection. So if we start to see antibody levels kind of decrease, we start to worry about those infection risks going up. So it might put sort of like a sell-on date a little bit to some of those medicines, and make us kind of then at some point make that decision of like, hey, maybe we should look at some of the other therapies that don't affect that as much, and try to find that balance. So that's kind of a little bit of a broad review as to how I think about it. Did that make sense? Any questions about that? Big concepts, at least. Good. Awesome. All right. Was there a question coming? Yeah, perfect. There.
Do you see any potential in the future for more use of low-dose naltrexone with multiple sclerosis?
Yeah, so I'll repeat it in case other people can hear it. It's about the use of low-dose naltrexone. Low-dose naltrexone is kind of an interesting drug because it developed in Germany many, many years ago, and the original trials were something like 10 or 20 patients. It was a really small study. And unfortunately, I think just because their money wasn't there, like pharma really hasn't invested in it much. And so the true benefits of it, I think, are always kind of hard. When I look at drugs that have kind of gained attraction on low numbers, I'm always a little bit cautious because we've had a number of things that we kind of got hot on that once the big trials kind of came around, they turned out not to be so hot. And so I think it's sometimes one of those things like, what's the risk? If it's expensive, maybe I wouldn't do it. If it's cheap and the risks are low, then I'm okay with it. And I think low-dose naltrexone kind of falls into that category a little bit. It's a low-dose opiate. And so how much does it help with sometimes? And it kind of works more as a blocker than a stimulator of the opiate receptors. So it's a little bit of a tricky molecule for the most part. But you're trying to kind of balance, again, things out and what does it exactly do? And again, the data for it just wasn't there. So I think it'd be one of those things that'd be great to kind of see bigger studies and try to kind of be able to kind of counsel better about it. I think it falls under the category of just stuff we don't know much about yet, unfortunately. I point out some of these examples, for example, the things that seem very safe. So like biotin, typical vitamin that you can get over the counter. for like thicker hair and nails and that kind of stuff, was used at really high doses. And it was thought to be helpful for progressive. The early initial trials were really showing some good data for it. They did the big trials, and it turned out it didn't have much of an effect at all. It actually interfered with some of the assays. So if you have like thyroid disease, the assays that are being used for measuring thyroid hormone levels and things like this, and that's just one example of many, got messed up by taking that much biotin. So you had to, again, kind of check it out and that kind of stuff. Recently, the simvastatin trial, so a statin that looked pretty promising in the early studies, reduced the shrinkage. Sorry, so this is the double negative. Brain shrinks, it reduced how much brain shrunk in progressive disease. They did the big trials, and they just announced that a couple months ago. It didn't quite pan out as much. Not fish oil, what was the other? Alpha lipoic acid had a big trial. They actually stopped the trial because they had a few people that developed some side effects associated with it. They will restart the trial. And I think we'll hear about it soon as well. You know, those kinds of things. So I think it's always like stuff that we tend to think about being somewhat fairly benign that we just need to be careful about. And everything sometimes in moderation. We talked a little bit about vitamin D. We push vitamin D. If anybody's come through the clinic, you know, we talk about taking some vitamin D. Vitamin D, some studies suggest that it helps reduce the number of attacks. That effect is probably pretty small, but it does help you kind of get calcium and absorb that calcium in normal meals and things like this, which is important just for bone health and things like that. The problem with too much calcium, and there's a neurologist out of Brazil that's been pushing sort of this protocol where they do like 100,000 units or 50,000 units of vitamin D every day, is that then you can almost kind of get toxic and start having to pee out too much calcium. And so then you start forming like kidney stones and things like this. And you can end up with too thin of bones because now you're just peeing it out. So again, just finding the right doses of these things becomes kind of the warning symptom for a lot of these things. We could talk a little bit about some other emerging type things, if there are any questions about any other supplements or things like that that people might have. Not necessarily. That's fine too. Perfect. Yeah, in the back. Okay. Yeah, so the question was magnesium and which one is the best. I'm not an expert, but I know that there's a lot of different types. So I think part of it is trying to figure out like what you're using it for, because we do use it for a lot of different things, and sometimes the side effects are our friends. So for example, sometimes it can help move gut. If you're having constipation, which is pretty typical in MS, that can be a helpful thing. So I think sometimes for that it's magnesium sulfate, if I remember right. But again, I would fact check me on this. Citrate's better. I'll see. People know I learn all that every day. Sometimes we use it for cramping and spasms, and that can be also very helpful for that. And some people report that they just sleep better with magnesium as well. So I think there's just a lot of different uses that you can kind of use for that. Any other ones?
You indicated that a lot of clinicians are now going to high efficacy right up front. It seems that I could be off on this, that a lot of the higher efficacy medications seem to have more side effects, especially can be quite serious like PML or increased chance of cancer. Do the drug manufacturers track like increased chances of cancer over 10 years? Or is it like one cancer patient 10 years, we don't worry about it? How do they track those things? That I'd rather have MS than cancer. So, I mean, how do they track those kind of things from reports so people can make informed decisions?
Yeah, so great question as to how do we track side effects, and particularly like things like cancer or PML, kind of the brain infection that has a line name this long that's hard to pronounce. So progressive multifocal leukoencephalopathy for those that really want to know. So let me see where to start with that question, because that's a big one. So the companies do track this. So for the bigger side effects, I would say they do ask us, for example, to report it. They ask patients to report it to them. A lot of them will have follow-up calls with patients to kind of keep track to see how they're doing. It's good business on their part sometimes, because it encourages that you keep taking their medicine. So, I mean, it's a little bit of a yin-yang. The other part where that gets reported, for example, is also the FDA. So the drug companies then report that to the FDA. We can report it directly to the FDA, or so can you as well. And so that goes into a database called the FAERS database. And we can keep track of those things through that as well. The other way that sometimes people track these things, and usually this is more the drug companies when they're trying to investigate where this is through claims database type studies. So claims put in through an insurance company. Insurance companies, you know, there's a few, so they tend to kind of have hundreds of thousands of lives that they're associated with it, and so they'll see a lot of patients, or millions of lives sometimes, that will be on certain of these drugs, and they can kind of be like, how many patients on this drug are also getting diagnosed with breast cancer or things like this. And so that way it gives you a little bit more of a denominator, so you know, like, out of how many people are we actually talking about, or versus sometimes these FAERS databases and this FDA database is sometimes like a good way to kind of be like, did somebody else report this? But it's a little bit hard to kind of know, like, how common is this? Because you're kind of wondering, are people reporting it or are they not reporting it? So that's where I would use the FAERS database. The claim stuff gives you a little bit more of a database. But a great example of this, for example, was the reports around breast cancer with Ocrevus. So for people that didn't know, Ocrelizumab, when it was going through its original trials, they found a number of patients who developed breast cancer in that trial. When they look at the patients in that population, right? And you have to think that 3/4 of the patients in these trials are women. They're not allowed to be over the age of 55. And so if you look at what are the cancers between ages of 18 to 55 in women, the cancer that exists is breast cancer. And so what is that range? Well, we know from kind of these claim tests that there's a range where we tend to expect, you know, some chances of seeing some of those cancers. And in the original trial, if you kind of expect that the average number of cases is some level, we're not sure what that level is. And so we put a confidence interval usually around that to kind of say, it's somewhere in that range. And the number of cases came out to be at the upper end of that normal range. That prompted that with the approval of the drug, then the FDA said, okay, we can approve it, but you need to keep monitoring this as a special interest, and we want to get more information about this. As the studies kind of went on and the number of patients on that drug kept going up, that estimate for those numbers kept drifting down to kind of that average. And they looked at that average using a couple of different databases, usually mostly Europeans, because they keep track of general population better than us. You know, they usually have one insurance company versus, you know, here we have different types. You know, we have Medicaid, but we also have United Health and things like that. And so we tended to kind of see this drifting down to kind of a number that we could kind of expect to be in the normal range. It's always hard because every year I have somebody getting diagnosed with breast cancer. And so then it's always kind of tough to know, is that just, if I'm following 700, you know, I see about 1,000 patients with MS, and I would say probably 750 of them are women. What are the chances that if I see that many women, that I would see a breast cancer case? It comes out to be what I would normally kind of expect to see. When you start to see sort of infections and things like this, PML is kind of the opposite end, where FAERS then became a really good source for that, because the drug got approved and there was no cases of PML. But within that first year of approval, people started to say, hey, this infection, like MS patients don't get this infection. You know, I mean, this infection is usually on immunosuppressed patients. So the main people that we tended to see this in were patients with kind of blood cancers where the immune systems are low, or patients with chemo, or HIV patients. And so with these 3 cases, there was like, hey, this is a weird signal, right? So then there was 3 of them. And so then they were starting to kind of look at and say, hey, are these patients, is this above that signal that we normally would say? And 3 is 3 more than 0. So it kind of would jump out and say, hey, we need to pay attention to this. And that's how PML, you know, basically led to Tysabri coming off the market until we had better understanding as to what it was, who was getting those cases of PML, and things like this. And they identified certain risks. You had to be on drug a certain amount of time. It was patients who had traditionally gotten some chemo. So in the early days of MS, where we didn't have a lot of other options, chemo type drugs were sort of the treatments that we had, much more so in Europe than in the US. And that's why there's a lot more PML, we think, than in the US. And so with time, we didn't have a lot of other great drugs. Mitoxantrone was probably the only real high efficacy drug that we had, and that caused heart issues. You can only get so many number of doses before the side effects just prohibited being able to get that drug. We don't use that drug much anymore. But then they were, because there was not other options, they said, hey, the risk of PML for patients with bad MS was worth it to kind of bring it back on the market. So the patients actually went to the FDA and said, we need this drug on the market again. So that came back in 2008. A few years later, they developed this test called a JCV test. So JC is the virus that causes that infection. And just because I think it's kind of cool, you know, we'll talk a little bit about it, but we all probably have the JC virus. About half of us will have a positive test on that assay. It doesn't measure whether you have a test. It's a bladder virus. It doesn't cause any symptoms. It doesn't do a UTI or anything else like this, but it can mutate and become a nerve type virus and cause that infection. So if you have a drug that prevents the immune system from getting into the brain, like Tysabri does really well, then there's a chance it could kind of, the mutated version could kind of hang out and be protected from the immune system and start to cause that infection. With that test, the numbers have come down some, so we're seeing less and less of that PML risk. And it then becomes this risk of trying to say, what are the odds of getting? So almost all the drugs have had some risk associated with it. Aubagio or teriflunomide had 1 case associated with it. It probably was a carryover from somebody that was on Tysabri. So we often don't count that one. We usually say anything within 9 months of coming off Tysabri is probably related to Tysabri. That 1 case was at 10 months after Tysabri, so hard to know. In the early days, there was a number of cases on Tecfidera. If we looked at the lymphocyte counts, most of those cases were in patients whose lymphocyte counts were really low. Most of the times in the trial, they were cut off at 500 where you couldn't get treated. But for some reason, when that drug got approved, people were using it with lymphocytes that went below that somewhat regularly. And so they identified, hey, this is happening at that rate. If you cut off at 500, there was been a handful of cases out of like hundreds of thousands of patients. So it's about at least 1 in 100,000 risk of getting it. So pretty small risk when we start to kind of actually put numbers to it. Ocrelizumab has had, I think, 3 cases that were not associated with Tysabri. And they're up to, I think, 300,000 or 400,000 patients now on Ocrevus. So again, the numbers tend to be fairly small when we start to kind of look at what those risks are. I agree, it sucks. What we tend to see a lot tend to be things like sinus infections, upper respiratory infections, urinary tract infections. And so for some of those things, then it's what's the risk that it's related to the drug, for example, right? So sinus infections, a lot of times we do tend to think could be associated more with these B-cell depleting therapies. Urinary tract infections maybe less so, because that's a different part of the immune system that tends to do that more so. But sinus infections can also be because you have a deviated septum and things just kind of get blocked off, or things like this that you do need to kind of get those things checked off. So that's a little bit how I think about sort of the risks, around cancer and infections. And we still monitor those things. The S1Ps, especially like Gilenya, recently we started to associate a little bit with HPV type infections and some of the kind of cancers associated with them a little bit. And there's been a handful of those kind of cases. But it was these reporting mechanisms that led to example, some of the fungal brain infections that we're seeing with Gilenya that we haven't really seen with any of the other drugs. And so then it's kind of like, how do you measure one case of PML compared to the number of sinus infections to kind of balance that out? That gets tricky. But that's kind of what we try to do the math with around some of these things.
We did have a question submitted online. I use Biotin, which is high doses of biotin, and NAD. Do you have any comment on that?
I don't know much about NAD. It's part of the reactive oxygen species, sort of free radical type stuff. So we tend to think that these are things that, if we can protect against damage from, oxidative damage and things like this, that it's probably a good thing. And there's a few different compounds that you can kind of get over the counter that might help with some of those things. What was the other one?
It was high dose biotin and
High dose
NAD.
biotin.
Mm-hmm.
So, and high dose biotin is really hard to get. So, I mean, for the over the counter stuff that we're talking about, like for nails and hair, it's like 1 milligram a day. The dose that they were studying for this trial was 100 milligrams 3 times a day. So, like, it was a bottle a day of over the counter stuff. If you were taking a lot of pills, you could get it. Mostly, you had to get it compounded, so pharmacy would make it for you. Or the other option was, somebody actually bought like a science scale and got it from like a science distributor and was measuring powder, and trying to balance it out. So, I mean, you can get really fancy with some of these things, but that's high dose biotin. I don't think that these doses over the counter come anywhere near that. Sometimes I've seen 10 milligrams, but that's about as high as I've seen with pills.
Another online question was wondering about the status of Sativex coming to the market.
Yeah, so Sativex is a cannabis byproduct, basically. It was pretty much cannabis. I mean, it was like a 2-to-1 ratio, pretty standard dose, cannabinoid formulation that was purified out. And it was being looked at for spasticity, and they didn't pan out much, and so the company kind of stopped pursuing it. There are some newer versions of this that are starting to come out and get looked at. I don't know much about this, but I'm going to make some stuff up maybe, so correct me if somebody knows more about it. One BMS, I think, has a compound, for example, that, cannabinoids work because we have cannabinoids in us. They're part of some of how the cells talk to each other. And so when you make stuff, you have to have enzymes that break it down. And so their compound inhibits the enzyme that breaks it down. So you create artificial levels of higher levels of the cannabinoids that you normally would make. And so it's looking at trying to see if your own cannabinoids with higher levels that way might be beneficial for things like spasticity. So one of the issues that did come up in some of the trials, we had a study in Parkinson's disease with some of these compounds, and they ran into some issues with liver stuff because the oil for isolating the compounds and, this kind of stuff. So again, just trials are great. We obtain a lot of information from them, but sometimes there's a lot of compounds that fail during these trials. So, wait for the trials. Don't do a lot of stuff outside of trials would be my recommendation for a lot of these things.
What about other general advice around cannabis or thoughts?
Yeah, so polarizing topic. So hopefully I don't offend anybody. I think cannabis has a lot of interesting qualities to it that a lot of people obviously find helpful with their MS. So we did a survey about 6 years ago, and it turned out it was probably the highest symptomatic drug in our MS population. 38% of patients had tried and used cannabis in the year prior to us doing the survey. Exactly. Yeah. So there's 3 things primarily that people found it helpful for. One was sleep. The other one was pain and spasticity, sort of as a cluster of things. A couple of people found it for appetite. I mean, that's more on the cancer side of things, not so much on the MS side of things. But those were the 3 main things that people did find it, reported it finding helpful for it. Side effects, sedation primarily was kind of probably the biggest one associated with it. And most people tended to gravitate, I think a lot of people tried CBD only type products, but they ended up finding that the THC was probably important to have with it in order to kind of have some benefits from it overall. If I'm providing recommendations, which for people that I know, I try to push things this way, is purified stuff is better than non-purified stuff as much as possible. I don't have a problem with nicotine, but I try to avoid the coal tars that come with cigarette smoking. So I kind of do the same thing with cannabis. I try to kind of recommend purified products over using joints and smoking it. Vaping's kind of in the middle. You still can get a lot of chemical inhalation from that kind of stuff. The one thing that I get a lot is the oils don't work for me. The joints do. And one of the things to think about is just drug pharmacology a little bit. So I won't get too technical, but let's see if this helps a little bit kind of explain the difference. When you do something inhalation-wise, you get it really fast. So your drug levels basically go like this, and they hit you really hard and fast. So your doses can be pretty low, but they don't last very long. The orals tend to look much more like this. And so they don't get that high, but they last longer. So if you're trying to go to sleep, this might be good for people who have maybe some anxiety issues or can't shut off their mind. It kind of knocks it down, they're good. Most of our MS patients that have sleep issues, it's more the staying asleep that becomes an issue. So if you're smoking it, it won't help you with staying asleep later. The problem is recognizing it is this isn't going to hit you right away. It's going to take some time for it. And when you look at the dose overall, then you have to do bigger doses because it's going to last longer. So then you end up having to do doses, and that's fine. You can go something like this, and that's okay. But it's just recognizing that your milligrams and things like this are going to be a bit bigger. So most of the times, then that does kind of provide some help if the drug provides.
For
Yeah.
pain, because my current doctor was suggesting that for my neuropathy in my legs.
Okay. I haven't used it much for pain, but we use it for pain, like migraine prevention and things like this, quite a bit. So just because I haven't heard it, obviously I didn't know what magnesium we were using, right? Doesn't mean it might not be helpful, but I think there's a logic behind it to some extent. We use it a lot in MS patients for, besides migraines and headaches, also for tightness. So for people that are on muscle relaxers you know that they're very sedating. This is a little bit more of a localized thing. The limit on Botox is that you can't use a lot of it. You're kind of capped as to how much you can kind of use. And so because of that, you can only use it in certain muscles. You might use it in, usually it's like, if you think of like leg, you can use it for a leg. If you need to do both legs, it gets really hard. So if you're having things that are like much more specific, I got this muscle here and it's really tight. They use it a lot like for another disease called cervical dystonia, where the muscles in the neck can get really tense and end up with kind of like turned heads and things like this. They can kind of loosen those muscles to kind of relax them. So when we talk about focal spasticity, that's kind of what we like Botox for a lot. And sometimes we do that on top of the orals, which work a little bit more kind of systemically. But I think it's reasonable, and we do have a fair number of patients that get those injections for that.
Hi, first off, Rob Mazzani, I'd like to thank you for coming down here. I really
Yeah.
appreciate you coming down here. We saw you last time you were down here. And rather than going up to hand shows all the time, this is a great pleasure for us. I do have a question though on, you can maybe get into a little bit of the science and methodology behind the Cionic Sleeve
Yeah.
and you know, how that is
Perfect.
to work.
Yeah.
We saw the testimonials online and I mean, they look fantastic, but you know,
Yeah.
the 6 minutes you get, yeah, I'm curious as to your
Yeah, so I
professional
can tell
opinion.
you what I can kind of tell you as far as what I know. No, and I'm happy to come down. You guys are always a great audience down here. You actually show up in numbers. So it's fun to come down here. When I think of, sometimes you'll hear about fees or I forget what that stands for, functional electric. There you go. It is the early versions of this included things like Biotin NAD and Walkade, and those work primarily by stimulating nerves. The early ones basically worked on foot drops, and they hit kind of the perineal nerve. It senses when you're going to push off, and it shocks it, and then it kind of helps you kind of lift up and push off. Yes. Testing. That better? Keep going for a second and see. And so some people had a hard time with just kind of being able to tolerate it. Recently, they did come up with a cuff that goes around the hip flexor, so you can kind of get a little bit more of the like knee elevation muscles. The big muscle groups that tend to get affected in MS a lot of times it's the foot drop, so kind of being able to kind of lift, and then the other ones are the hip flexor, so kind of lifting the knees up. The Cionic Sleeve, for people that are aware, is it's a true sleeve. It's kind of this neoprene type thing that has electrodes that stimulate the muscle. And so I forget the number of them right now, but it's they have sort of a set and array that kind of will hit sort of your hip flexors, and then also the ones that help you pull up a little bit. Patients tend to report that it helps, that it's a little bit better tolerated because that charge is a little bit more diffuse. It's not just hitting a tiny little spot. It's a little bit more cumbersome to put on because you're kind of slapping these electrodes and have to put the sleeve on. And then it's a little bit more programmable. It connects up to your iPhone, and so you can actually kind of dial up or down the individual electrodes that are there. Unfortunately, they're not cheap. So yeah, so I mean, we've had patients with the Biotin NAD and the Walkade, more so the Biotin NAD. The Walkade I haven't heard about much recently, and then I probably have at least 20 patients plus now on the Cionic neural sleeve. We have a setup for people that don't know on the 4th floor, just underneath our clinic, with physical therapy, where you can kind of try it on with them, just to kind of see if it's a good fit for you before you kind of commit to buying it.
Talk about 7 clients of ours that are using this in Colorado Springs. And our physical therapist that's worked with us for years was the first one that I knew of to talk to me about it. And she came walking up to me in our office, and I just about fell over. I mean, she walked right up to me, and I'd never seen her stand straight. So I was so impressed with that. But I guess she always says, I'm not a spokesperson for this. I'm not getting a kickback. But she said, I'm just so impressed with this product. So, you know, she'd be a great one if you had questions in the Springs about it. And then also.
And then, full disclosure, I'm on their scientific advisory board. But part of that was because I saw some early patients that were on it and had really good results. So kind of just started having conversations with them about it. One of the things practically that I do like about them is with the other devices, people had to buy the whole thing outright. And it's usually like, I think 6,000 for the foot drop one and 8+ for the top one for the Biotin. The Cionic one is around $3,000, but it's a little bit more on a rent to own basis kind of stuff, a lease system where you kind of pay monthly. So a lot of times, if you can't make it up to the clinic, they'll mail it out. You can try it out. I think it's like $300 or $350 for the first month, and then $250-ish, I think, for kind of the follow-up months. So you can kind of see how it kind of works. And the part that I got interested in is there's been patients who have actually developed a little bit of strength back up on it, you know, because it allows you to kind of exercise, move around a little bit more normally and things like this. A patient that kind of stopped using a cane, you know, kind of just bought them enough extra, you know, where, you know, if they're going longer distances, they'll still use it for balance and stuff. On the negative side, I had one patient that just was burning out the unit, but that I don't like short circuiting, like it would work for 2-3 weeks, but then the unit would go defective on them. And so, but that's been 1 out of probably like 20, 25 patients or something like that. So I think overall it's been a pretty positive thing for a lot of people. And I think sometimes it's just worth trying it. I think sometimes it gets a little complicated if you need 2 versus the 1, you know, some of those things. But I think it's been interesting. And the part where I have been kind of seeing a little bit of kind of on the science backside is it keeps track of like number of steps that you take, how much power you're putting, how balanced your walking is, and things like this. And so they're starting to do some studies in tracking their patients to kind of see sort of like what kind of improvements are they actually getting and things like this. And my understanding is maybe this spring they might publish out some data. So yeah.
We did have a question submitted online. Those of us that have had MS for more than 40 years and have not taken a DMT before, now this person is being offered Copaxone or generic Tecfidera to try to slow progression. General comments?
Ouch. Maybe to take a step back a little bit and kind of just talk about MS. And I think sometimes the challenges that we have with MS and the terminology that we have, it's a messy disease. On the way down here, I was talking with one of our colleagues who was trying to do maybe a value-added sort of response about one of the drugs. And there was this concept of like confirmed disability progression, which is like worsening, and then CDI, confirmed disability improvement. And you kind of think they're related, right? Because if you're either, you know, if you're not getting worse, maybe you're getting better, and you're kind of using the same scale. But they're measuring kind of conceptually 2 probably very different things. So, you know, we talk about it being relapse and remitting. You have a relapse, and then most people get somewhat better, about 50% of relapses end up giving you some permanent damage associated with them, with that clinical event. The problem is we know that this is a little bit of like the iceberg, right? So these are just the clinical events. And one of the guys I work with a lot has the swimming pool model, because the stuff that sticks up are the symptoms, but the stuff that's kind of underneath is literally 90% of the disease activity that's happening in us. So if we don't look MRI wise, we might miss most of the iceberg, right? And it's almost the same proportions as what you have for an iceberg. And so it's a kind of a great representation a little bit as things kind of go. And as you get older, you know, this model kind of drops and some of the damage that's been there might come up, right? So you can get a little bit of disability, worsening just, you know, from aging and other things like this. So it's recognizing that a lot of the inflammation doesn't give you symptoms. A lot of the symptoms, likewise, aren't reflective of this, because there's another concept called pseudo relapses, which are real symptoms, but they're there because your body just isn't working quite as well. So if you're having an infection, it's hot outside, you're just petered out because you haven't slept or anything else like that, those old symptoms will come out. And so those pseudo relapses then almost can kind of become another big arrow like this. If you look at, so some of the work I'm doing with Stephen Krieger, who developed the model, is we're then looking at clinical events and clinical trials to see how many of them were associated with MRI disease activity. And so when we tie the two, for example, on high efficacy therapies, and we looked at ublituximab versus Obagi or teriflunomide, we saw that in teriflunomide, about 80% of those events had MRI activity associated with them. But it was only 20% of those on ublituximab that really had MRI disease activity associated with them. What does that mean? It means that we have taken out so much of the inflammation that most of the clinical symptoms that come and go are really these pseudo relapses and not stuff associated with inflammation, because we just knocked it out. With drugs that don't work quite as well, then the amount of disease activity, inflammation still exists, so you still tend to see a lot of MRI activity associated with those events to kind of drive what those relapses are. So we have disease activity without symptoms, we have symptoms without disease activity, and then you start to talk about progression associated with this stuff, right? So if you have, I'm not even sure what that looks like anymore, but if you have progression, right, you can accumulate, you know, and this then leads to sort of that brain shrinkage and things like this, and that progression gradually kind of builds up as you get older. The problem with progression is that this doesn't measure whether it's MS specific or if it's from other things. You fell, you broke a femur, now you have some deconditioning. Any number of stuff with just getting older, usually associated with deconditioning, right? So the bigger umbrella term we would call worsening, but the part that's specific to MS we would call progression. Now, the question you guys always ask me is, how do you tell the difference between the two? And my answer is, I have absolutely no clue. Sometimes it's easy, right? You get admitted for COVID, you're in the hospital for a month, you know, or something like this. I can tell you, you're probably going to decondition, and that big hit was probably mostly related to deconditioning, less to MS kind of worsening associated with that. But even our terms aren't great, right? Because I just told you when I started, right? CDP, confirmed disability progression. It should be confirmed disability worsening, because we didn't separate whether it's MS from other stuff. We just can't. So this is a little bit of like where our terminology has just become so tough to try and separate these terms that it makes it hard. But with some of that tutorial, hopefully some of these other things make a little bit more sense. And I forgot where I even started with this conversation with. So no questions.
I was going to see too, if you could, we had a request to include progression independent of relapse activity, or PIRA, in this discussion.
Yeah.
And then the original question was going on a DMT after you haven't been on one for 40 years.
Yeah. So perfect. So because the number of attacks goes down, you know, so much with age, after 40 years, you're at this bottom peak of stuff. And if you were having disease activity and you just wanted something to be on something because you started to have disease activity, but you saw the light and you want some treatment, I think that it might be reasonable to do that. But it's to treat relapses, because those drugs, as far as really treating disability, treating progression, they don't fix what's broken. None of our drugs fix what's broken. And those drugs, as far as being able to slow down progression, don't do much. Most of our drugs don't do much. And even the drug that's approved to treat progression may not do much. So when we look at sort of progression with Ocrevus, for example, we see that a lot of that was driven by people who had either inflammatory disease activity, so this MRI piece that maybe wasn't showing as a relapse, but was probably driving some of that disability progression. It was younger patients and those with active lesions. We like to try them because sometimes we do find that those people who have some underlying disease activity and things like this, and that can help slow things down. And it's the best that we have. So we like to treat that. It also works for relapses really well. And so that's part of the reason why we're saying not just us, but across the country that so many patients are ending up on those drugs. Because if you have the option to treat both parts of the disease, a lot of times you end up kind of going for that. PIRA is, so confirmed disability progression, when you're looking at disability, and let's talk about relapsing for the most part, is you have a relapse. Is that showing up on camera? Am I too far over? Okay, so if you, sorry. So if you have a relapse, disability worsens, and then hopefully you get some improvement. But sometimes you may not get improvement. And so you check that disability, it's gone up from here. And then the confirmed part is that either at 3 months, 6 months, so you'll see like confirmed disability at 3 months or 12 months. Sometimes they do it by weeks just because, you know, they want to make it complicated. So you'll see it at 12 weeks or 3 months, right? And so if you do another point, if this point's higher than this point, then it's confirmed to be elevated. For PIRA, it's basically the same concept, but you get rid of the relapses. So it's, we didn't see a relapse, we were just checking you in clinic, and your disability kind of, and going this way, you hit a point here, and then you confirmed it at this point there. So this is progression, okay? And we talked a lot about PIRA and relapsing trials, and people make a big deal about PIRA and relapsing trials. What you're measuring is progression, right? So what's happened is, as I said, those drugs are so good at taking out, you know, the relapsing inflammation, that what you're now starting to measure in some of these trials is some of those patients that would have become progressive and are having some disease activity, you know, some worsening in their disability that is not associated with relapses or other things. What it doesn't take into account is, was there an MRI lesion that popped up with this, that maybe you didn't have symptoms, but caused a little bit of damage associated with that. So there's other terms that are like, you know, progression independent of relapse and or MRI activity. And if you're not confused by now, congrats, because that confuses the living crap out of me, and I think about it all the time. So, and especially that drawing now, I don't know what's going on. But all right.
So we know that the drugs that we're taking are just preventing the progression of our disease. So what recommendations do you make to your patients to sort of treat their symptoms? Stress, fatigue, the things that come along with MS that those drugs aren't getting rid of. Do you have specific things that you recommend to your patients to do?
Yeah, so that's a great question. I could talk for that on hours. So if I start going on too many tangents or forget the question, just rein me in. I think that in trying to kind of treat. So with the drugs, right, we hope to stop inflammation, and we monitor to make sure that that's the case. And sometimes if not, then we'll kind of continue looking at that stuff. I would say that when you control inflammation, it does let the body sometimes heal itself and kind of control, allow some repair to kind of have things kind of improve that way. And so we don't want to promise it, but we do see some improvement sometimes from that, the CDI, that confirmed disability improvement. And it's in the rate sometimes of like 10, 20%. What are some of the things that we can do for that stuff? So the number one symptom in MS is by far fatigue. To talk a little bit about fatigue, it's important to recognize that there's a biology to this, right? Signals that make it through nerves, right? It's a little bit like trying to send electricity through wires. If you have high voltage lines, the resistance to that line goes down. Some nerves take advantage of having myelin around that to do that more efficiently. So if you do have nerves that have lost that insulation, that myelin, stuff sometimes just peters out. So trying to get stuff from point A to point B takes time, takes energy. And if there's a lot of stuff missing, it's going to take a lot more energy. And sometimes it just stops from getting there. I would point out that you still need to have that wire. So as far as like remyelinating therapies and stuff like that, and maybe we can talk about that a little bit later, comes into play for that as well. So, so there is, so that can take more energy. Sometimes it's a little bit kind of like when you're trying to think of a word and you can't think of the word, and then you spit there and you're spinning your wheels and you're trying to kind of think of another way to say the same thing, right? You can get there, but it just takes more time. It's not as efficient, right? The nerves are kind of the same way. Sometimes you can kind of get there. It's just not the most efficient way to do that, right? I can walk with the boot that I got on, but it's not efficient. so I get there, but it's one of those things that just takes more energy. So to end up by the end of the day to be more fatigued, right? So what do we see for that fatigue is in the morning, people tend to feel like they have more energy. As the day goes by, they peter out faster, And then I talk about fatigue versus fatigability, right? So in the mornings, you might be able to do stuff. By the end of the day, it's fatigued out versus just kind of fatigue, right? What are some of the things you can do to improve fatigue? The number one thing by far is get good sleep. That gets affected by many different things. So it's trying to kind of get a good history to try and see what are the issues while you're not sleeping. Is it stress? Is it because you're having spasms? You're having to wake up 10 times to go pee? All those things. So sometimes you work on sleep by trying to treat symptoms. That can vary from a lot of different things. Sometimes it's us. Maybe we send you to the urologist to kind of help with some of those things. Once sleep is good, then you can start to kind of work on sort of the stimulant side of things. For good or for bad, things like the true stimulants are a pain in the buttocks to try and actually prescribe. You have to do monthly scripts. They're hard to get. We just don't see you monthly to try and get those and things like this. The medicines that I tried to start off with are amantadine first. There's actually a trial for fatigue and MS, and it can be helpful. And then you have modafinil or Provigil, the newer version of that called Nuvigil, which can kind of help with some of those things as well. But if you don't take care of sleep, you can be on crack, but if you were up all night, it ain't going to help much, right? And so that's a little bit of kind of what you're trying to kind of balance out. The other thing then is to try and kind of help those nerves be as functional as they can and as efficient as they can. So that's where, diet and exercise become really huge parts of that. So from an exercise perspective, if you're 50 pounds overweight, right, that's 50 pounds you're carrying. So if you have fatigability, that fatigability is only going to get worse, with that extra weight. If you can lose that weight, be healthy in that perspective, right? It's just going to make it that much easier for you to get around, less energy every time you take a step, kind of stuff. If there's foods that you're not tolerating well, you're lactose intolerant, you don't tolerate gluten, I would cut those those products out of your diets. I worry sometimes with how much some of the online diets recommend cutting stuff out, because I think sometimes what happens is you get to a point sometimes where you start to look at that food plate and it's just like reminder of MS, right? And so trying to kind of just take a step back and be like, okay, can I make it healthy? What's the minimum stuff to kind of make it healthy? So the minimum, I think, is just trying to cut out processed foods, trying to reduce the amount of sugar or of salt, pure sugar in them as well, things like that. But trying to kind of keep it simple, right? Lots of fruits and vegetables. So, in broadly terms, like, the Mediterranean diet, the DASH diet, those kinds of things. If you don't tolerate gluten, cut out gluten. Sometimes by paying attention to those things, you feel better because now you're actually paying attention to your food. Sometimes you don't tolerate them and you realize that. And sometimes you just have to cut out certain things to kind of realize, like, hey, maybe I'm just not tolerating asparagus and I got to cut out asparagus because that's, something in me is just not tolerating it. From an exercise perspective, it's, then is if you're stronger, you can do that. There is a little bit of a balance that comes in with exercise because there's only so much sometimes you can do. The idea of breaking up exercise, so you're not overdoing it at each step is great. But if the exercise that you're into, for example, is pool, right? You're not going to go to the pool for like 5 minutes in the morning, 5 minutes at noon, and 5 minutes at night, because you're getting more exercise just getting ready to go to the pool, right? And so you do have to find sort of that balance of like, what can I do? What's reasonable? What's the exercise that I like to do? My wife likes to swim. I'm a floater, it's just not going to go for me. I try to play soccer, so that's what I like. Running, just I get bored and it's not for me, right? So if you find the stuff that you like to do, then it doesn't seem like such a chore. You'll just kind of do it. And I think that that's, we're trying to find those things. And then to go back to the original stuff about sort of like, what are the right exercises? It's safe stuff, right? Like don't fall, don't break a hip, femur, other stuff like that. That was a lot of stuff. But you have to, especially I think, with fatigue as sort of like that top thing, right? You can often find stuff to go after symptoms wise. I think the other piece to that is making small changes, and being careful about the changes you're making. It's very easy, especially at the beginning, somebody comes in and it's like, I got this and I got this and I got this. And here are like 4 drugs. Good luck, right? I'll see you in 6 months. Hopefully that works out for you, and you remember everything I put in. For people that see me, I'm not very good about telling you, start this medicine at this dose on day 3, then we're going to go up and try to do this. And then you're going to, because I don't know if 3 days is the right amount for you, right? So my philosophy a little bit is more to try and tell you, like, this is the concept of what I want to do. This is what I'm hoping the drug will do. These are the side effects. Go up. If you're tolerating it, go up faster. If you're not tolerating it, don't go up as fast. If you get sleepy, take it more at night. Try not to do it during the day. You can try to spread it out and do more doses if that's doable for you, as opposed to, having a drug that's sedating. You can, instead of getting all the drug up and getting really tired, if you can do sort of smaller doses more frequently, a lot of times you can tolerate it a little bit better because you're not getting to those high doses. And so then I just kind of throw some drugs and give you some guidance and say, try to build up to this dose. If that works for you, great. That might be too much or not. And then, maybe making 2 drug changes at most. And if we need to, we bring you in, every couple of months when there's a lot of stuff that we need to kind of change. Was that generic enough? But okay, cool.
We did have another question submitted online asking, why is it that hip flexor weakness and foot drop are so common in MS?
So we talk about, so I don't know that I have the great answer. It just is, for two main reasons. So when the brain and the spinal cord gets affected, you get what we call an upper motor neuron pattern of weakness. And that's the pattern of weakness that comes up. So hip flexion versus kind of pulling back, hammies get weaker than quads. And when you see that, then you know it's brain and spinal cord. If it's the opposite, then you worry more that it's peripheral nervous system. Legs more than arms tend to happen because they're longer nerves. So they're just more likely to get affected. And so we tend to see oftentimes either both legs slowly moving up or sometimes one side kind of crawling over to the other side. That's all I got on that one. Sorry. Yes.
So, oh, thank you. When I first started with my MS, you get your MRIs for every 3 months, every 6 months, but it was continual for a while. But they were always using contrast. And I know in the last few years, they're not using it as much, but the MRI machines are more advanced. But are they going to go back to the contrast just because I think they, I had a doctor that had to go back 6 years to find something because of the contrast that showed up when I was doing that, and now it's not showing up. So anyway,
Okay.
long question,
So,
but just.
no. So kind of what's the role of contrast nowadays with imaging? And I'll throw into this because this is another question we get a lot around, sort of like spine imaging versus brain imaging. Okay. So contrast is, it's gadolinium type products. It's a very stable drug. And the thought is that it measures inflammation. So when we tend to see that for a lesion, it helps mark lesions that actually have inflammation. It doesn't really do that. What it's actually measuring is areas where the blood-brain barrier has broken down and that drug has a chance to get into the brain. So that tends to go with active lesions, but it could be a lesion that has lost that activity and it just hasn't repaired itself quite yet. Most lesions tend to be active for 1 to 2 months on average. And so much beyond that, we can't tell how old the lesion is, meaning like, if it happened 4 months ago, 5 months ago, all I can say is that was not in the last 2 months or thereabouts. Big lesions will have contrast for longer. So spine lesions, sometimes I've seen them last for like a year plus, usually in other conditions than MS, because MS lesions tend to be a little bit smaller. The role of contrast then is mostly to kind of say, are we seeing something that's active? But nowadays, because we recognize that if we have a comparison, we can kind of say, hey, versus this MRI, there's more stuff on this one. And, you've been on drug X for 5 years, and, you have a comparison MRI from 3 years ago to now. Do I care if that lesion happened 2 years ago or did it happen 2 months ago? The answer is I don't care that much. What I care is that happened on drug X, and if you're breaking through on drug X, we should look at getting you on a better drug than drug X. So we kind of said, and we kind of hosed the radiologist a bit, because now they have to do much more of that comparison work for us. Contrast still will have a role because there's certain things when we're doing neurology in general that it helps us try to say, this looks like an MS lesion or not, right? So we have a lot of patients with MS who have meningiomas, that are like little brain tumors, who have little aneurysms or things like this. So a lot of times once we identify those, then we have to keep track of those. And so then we want that contrast to kind of monitor usually the other stuff versus the MS piece. If you're coming in with symptoms that are acute at that time, we will often do contrast because we want to see, is there something active to match up those symptoms? If there's something new, we're probably going to be fine from that perspective. There are ways that we started to recognize that we don't necessarily need contrast to identify that. So we can use actually the stroke sequences sometimes to kind of say, hey, that looks like something that's happening more acutely. It doesn't go back 2 months or a month, but it's really good to kind of sometimes go back a couple of weeks. So if we can get an MRI done pretty fast, that is one way that we can kind of look at that to kind of say that looks like it was still an active lesion. Did that answer the contrast one? The other issue where this became an issue was there was a study that showed that with contrast, it actually accumulates in your brain. And there was a theoretical risk that it could be toxic. Now, I've had patients that were part of studies at the NIH where they literally got triple dose contrast, right? Because if a little contrast highlights a few lesions, a lot of contrast highlights a lot of lesions. And they got MRIs every month for 3 years. If you do the math, it comes out close to about 80 doses of contrast. And those patients are doing fine. So, but practically speaking, if you can skip putting an IV in, it does take a little bit extra time to kind of pull you out of there, squirt the stuff, and then get you back in there and do those extra sequences. So usually it's a little bit cheaper, a little bit faster. And like I said, for the most part, it doesn't tell you much of anything new compared to the other stuff. For the reason why we're doing so many MRIs we think it's to kind of try and identify, symptoms that kind of go with it. But the main reason we're doing a lot of these routine MRIs is to try and identify lesions that don't give you symptoms. Because if they gave you symptoms, you're going to come in and tell me, hey, I got this new stuff and this is what's happening. And I'd be like, yeah, you got a relapse. We should probably treat it and kind of go from there. And so the number of lesions that don't have symptoms in the spinal cord is like 50% versus 95% in the brain. So your bang for the buck is much higher for the brain than it is in the spinal cord, which is why we try to kind of concentrate on the brain so much. If MRIs were cheap and easy and fast, yes, we would do all of it. And by the way, all of it doesn't really mean all of it, because we can do, just to kind of break it down, the brain, cervical or C-spine, thoracic or T-spine, and then lumbar spine. We can safely do spinal taps in the lumbar region because there's no spinal cord there. So for MS, since there's no spinal cord there, we don't need to do the lumbar spine. But you're still talking about 3 MRIs, the brain, the cervical, and the thoracic. And so for those 3, it's basically 3 times the amount of time, money, hassle, harder to schedule, so to get MRIs done at 2 in the morning, this kind of stuff. A lot of times if you're trying to do something fast, you got new symptoms, that is what you're looking at, and so if you can be there, for 30 minutes versus being there for 2 hours, that's a big plus, right? So if there's new symptoms where we're worried about something being in the spinal cord, then we'll do the spinal cord ones. So that's a little bit kind of why we try to kind of localize them a little bit.
We are down to just 7 minutes left, and we did have a couple questions come in at the end. What is the best way of measuring brain atrophy, and does it have clinical significance?
Yes to the clinical significance. So atrophy is our best measure to match up disability. Number of lesions doesn't match up to disability very well at all. There's scars, and you can have road rash that doesn't cause a lot of symptoms, or you can have a bullet wound that's a very small lesion that causes a lot of damage. So the lesions themselves don't match up well. Atrophy does. We can measure it technically really well. Machines can do this well. The problem is what they're measuring is noisy. Okay, so that's the problem. to put some numbers behind it, your brain shrinks about 0.25% per year. When we switched from a research scanner to a new research scanner 10 years ago, everybody's brain in that study grew 2.5%. So if you can do it on the same machine, it's great. Changing machines messed up everything. Your change from morning to night is about 1 to 2% within a day. Throughout the day, you hydrate the brain. At night, you're not drinking. You dehydrate it out so it shrinks a little bit. Hormone levels, I don't know what exactly it is, but there's changes from morning to afternoon and night. So your brain changes more from a day-to-day variability, from a machine variability, than what it's actually shrinking. So at the individual person, to take any one person, it's really hard to kind of say this change is meaningful. But when you start to put in these big studies, 500 patients or something like this, that makes a big difference.
We had a couple of questions submitted at registration about the recently approved Ocrevus shot.
Yeah. So Ocrevus got just approved and it's starting to kind of trickle in as a sub-Q formulation. Ocrevus is normally given IV. Rituximab, the kind of for years had done a sub-Q version of it. When we tend to think about sub-Q, though, it tends to be sort of a low-dose sub-Q, like a flu shot or something like this. They're still putting in, forget the exact amount, but like 37 mils. So it's, a decent amount. They put in something called hyaluronidase, which is an enzyme that kind of helps break the tissue a little bit underneath the skin to create a pocket for that fluid to go in. So instead of bulging out, it does kind of spread out for the shot. The nice thing about it is if you have difficulty with IV sticks, you don't have to find a vein. You can just put the needle sub-Q and kind of get the medicine in that way. It's a little bit faster. So instead of being there for, doing the infusion over 2 hours, you can put this in over 10 minutes. The pre-med time is still about 30 minutes. The observation period got a little bit shorter with the sub-Q. Tolerability, if you have bad infusion reactions, tends to be a little bit better with the sub-Q because a lot of the reactions that you get are not to the drug, but to the chemicals that those B cells produce when they're getting killed. And so if it's getting absorbed slowly because it's getting absorbed slowly from the sub-Q tissue versus kind of getting dumped into the IV all at once, it tends to be a little bit better tolerated that way. So I think it does provide some advantages to some people. I think some people would say, if I'm there and I'm having to do the pre-meds and being watched for some period of time, how much is the 10 minutes versus an extra hour? If I'm going to get Benadryl and I need Benadryl, which makes me sleepy, is a 10-minute nap from my Benadryl enough? Or, do I need a little bit longer for that nap? I think all those things are things to kind of think about when you're making the decision to take those options.
Do you know if there's a price difference?
The same pricing as far as it goes. There might be a little bit cheaper as far as infusion time and stuff, but that is like this much compared to the price of the drugs and what the infusion centers are charging. It's a big deal for Europe because they don't have the infusion capacity. So it's a way to kind of be able, in some places of the world, to get that access. It's a little bit less of an issue here. Still every 6 months. The only thing that changed, and this is kind of maybe a big deal for starting, is the first dose of Ocrevus is 2 doses split in half. For the sub-Q, you can do it all at once at the same milligram. Actually, the amount that gets absorbed is, to get it sub-Q to IV, you do have to go higher dose. So it's some random number like 987 milligrams or something like this. I forget the exact dose, but it's, yeah.
A question I normally ask, how do you see AI playing out in the diagnosis, the treatment, the imaging, and research and medical development with MS?
Yeah, so it's already being used. And the idea is, so the question was, how does AI kind of factor into all this stuff? We might need AI to figure out the new diagnostic criteria. They got presented at the last meeting we were at, and the presenter basically said these are really complicated. So I'm not sure what they're going to look like at the final result. They have used it to try and look at like brain MRIs and try to kind of sort out, like, is this patient progressing? Are they not progressing? And things like this. And they do find matching, right? The question is it better than sort of anybody else looking at those MRIs, and what's the benefit of that, right? If you see a brain that has a lot of shrinkage to it, that patient is more likely to be progressive than somebody that is not. They are using AI to answer questions. So like when patients call in, or we're calling in around some of the trials to try and sort out the phone calls and give you answers, right? Kind of like on ChatGPT or something like this. A lot of that's being triaged through AI already. And they're using it a lot for kind of like target discovery and things like this, you know, early on in the disease process. So it's getting used. I would say it's still kind of in the early phases of where it's kind of getting implemented at. But there are being efforts to try and see what it can kind of teach us about the disease and how to treat it.
And that is it for time today. Thank you guys all. I think you'll stick around for a moment.
Yeah.
Thank you for coming tonight. We're going to have the local resources next. If your questions did not get answered, we also have 2 Q&A sessions at the Education Summit on November 16th. And we don't have registration open yet, but our next Conversations on MS event will be December 16th. So please keep an eye on your email for those, and have a great rest of your night.
Thanks.